here, and what a crowd, and I need to figure out where my slides are, and while I'm doing that, thank you, Sarah. You know, this is such an incredible gathering, and I know we're going to have some of that time at lunch, but I just want you to take 2 minutes to turn to the person on your left, introduce yourself, and explain why you're here today. Just 2 minutes. Because that is what we are going to need to do to solve a very challenging problem, which is to shift our healthcare system, which is a sick care system, to health and wellness. And it will not happen unless we really work together at all levels, at the community level, at the state level, at the federal level. And I can tell that this group is ready to do that, and that is very exciting. Okay, so I'm going to go through a couple of slides and hopefully leave a little time for Q&A. That's my goal. So we are a 20-year-old organization this year. We're going to have a big celebration at the end of the year. And our mission is really to improve the nation's health by strengthening primary care. And our major focus, our major lever we focus on is payment. There's a lot of different levers, but that's the lever we focus on. And you can see at the bottom of the slide, what is our definition of high-quality primary care? These are principles that are articulated on our website that we just updated to better reflect whole-person primary care. Every organization in this room, if you haven't signed on to them, we have about 400 organizations. It's not individuals, organizations can sign on to the shared principles, and we would love to welcome you into this club. How we do our work is through a campaign called Better Health Now. Our campaign is not pay primary care more, although we hope, and that is our focus through value-based models, but it is focused on what we all want to achieve, which is better health. We're not a very healthy country. And that big umbrella brings in lots of different organizations. And that's what we need to do. This needs to be a huge tent, because those in our healthcare system who want the status quo are incredibly powerful. So to shift that, we really need to have collective action. So what does this campaign do? It's focused on 3 premises. Invest in what works. What we know about the evidence behind primary care, as my friend Asaf Batan said, is A+. It is the only part of the healthcare system where you invest more and you get better health outcomes. We know this to be true. So it's not that we necessarily need more evidence. We need political will, and we need to move decision makers. We also want to pay for what we want. We don't want to keep paying for expensive services. We want to be healthier, and we want more equitable care. And with all of these models, we have to make sure that we are not leaving our safety net patients or safety net providers behind. Too many models do that. And we have a growing movement. We have about 70 organizations, but we also are open, and we want lots of folks to join us through many, many mechanisms. So you can join the Better Health Now campaign and not be a member, that's fine. You can come to our webinars. We do a free webinar every single month. We want to be a part of a collective movement to advance primary care. I thought the slide got out. Our board of directors is very diverse. and reflects all of the different parts of our healthcare system, and that is actually important, I believe. You know what? This is my old slide deck, not the most recent one. Oh well. All right, I'm going to go with it. We changed the deck and somehow it didn't get updated. Right. That's okay. What we know is that our life, these are things that we know well, but I want to make sure that we are on the same page in terms of level set here. Our expenditures are higher than any other industrialized country, and yet our outcomes and our performance is so much lower. So I don't know if this chart ticks you off, but we're paying twice and more what other European countries are paying. And our life expectancy is 4 to 5 years below the Europeans. And that's, life expectancy, that's lifespan. Now if we talk about health span, that's a whole different matter. Many of you know we have people who are just spent the last years of their lives sick, just getting services to feed the beast of this healthcare system. So we want to improve not only our life expectancy, but our health span. And who can do that but primary care? And I really see a movement in this country that people want to be healthier. And all kinds of folks are talking about this, on the left and the right. And frankly, RFK, for lots of things I disagree with RFK Jr. about, our HHS secretary, he is actually talking about a set of issues that we also care about. We want better prevention. We want chronic disease management. So yes, we're working with the administration on these things because they're moving on those issues. We heard earlier about how our trusted relationships are declining. And this is the absolute secret sauce of primary care. All the evidence shows that when you are known, you are much more likely to get the treatment that responds to your medical condition, your psychological condition, your family context, your community context, and you're also much more likely to follow that advice. You're much more likely to change your behaviors when you're in relationship with someone who you feel has your back. Transactional care does not do that. So, and this is going to be super important to preserve as AI really gets integrated into healthcare. And I think that the relationship is going to become more important to people, not less, as technology becomes much more a part of our healthcare system. So I think we've got, the secret sauce to connect to patients, and they're going to want that. Also, we know that, there's so much going on with genomics and with the ability to understand with retinal screens what's going on with your future risk in terms of cancer, cardiac, cognitive decline. And once those screens, which are now available, they're being used in places like Hong Kong and elsewhere to see what your risks are at the age of 50, you're going to want to be teaming with someone who can help you prevent that future condition. And so again, I think primary care has an incredible role to play as we get much more sophisticated about personalized data and your own risk factor. So I see a bright future for primary care. I know we're at a low point, but I see a bright future for primary care. Even though the shortages are bad and getting worse. Again, I see a bright future for primary care because I see policymakers beginning to understand how critical it is to further support the foundation of our healthcare system, which is primary care. We see this rallying cry of the underinvestment in primary care as beginning to resonate with policymakers. They are starting to talk about the lack of primary care investment in their speeches, in their testimony, in their hearing. Today there is a hearing on physician payment. The Energy and Commerce Committee is having that hearing. We are providing testimony. The Doctors Caucus is soon to drop a bill with $2.5 billion more in new spending for primary care. We'll see if we can get it over the goal line. There's going to be opposition from many, including specialists. There is a bill that we expect to drop in June with $10 billion more for primary care. Senators Whitehouse and Cassidy. Now, will those be easy to come to fruition? No, but I think what we need to recognize is that members of Congress finally are getting it, that they need to invest more in primary care. That's billions. It's not you know, a little change in some code that delivers $14 more per patient. It's billions. So let me talk a bit about, you know, I spoke about federal policy. Let me spend a little time talking about why you all are here, which is to be a part of a social movement. And so I've been operating, you know, most of my career at the federal level. I've done a little bit of state work. And I was introduced to someone who's an academic at Georgetown, Leslie Crutchfield, who wrote a book, How Change Happens. If you haven't read it, it's worth taking a look. She studied social movements on the left and the right. So everything from marriage equality to gun rights. And these are the basic conclusions of her study. That we only will be able to change a narrative if we work at multiple levels, which is what I opened with. That there is no one solution, and that the successful social movements recognize that you have to be responsive to the issues of the community and of the state. And so, you know, Mothers Against Drunk Driving, they were not all cookie cutter. They had very different state-based organizations and even community-based organizations that had a different set of policies. So she calls it the 10-10-10-20. You have to allow for a lot of creativity. I think we also have heard this, that you can't just have data, which I am so excited about the data that New Bedford is producing and that other communities across the country produce, because I think that gives a real urgency for change. And it was exciting to hear how that data really sort of was a call for that community to get very serious about how they're going to respond. And they went from 1 doctor to 3 doctors at the community health center. That's real change. So we need the data, but we also need the stories. And so I would suggest to you all in the community that you have the data, but that you also surface the stories. And the frame really matters. Leslie talks about how marriage equality was not getting much traction initially. It was really framed as a right of gay people to get married. It wasn't getting any traction. It was reframed as, and talking first to straight people, shouldn't you have the opportunity to marry the person you love? Completely different frame, and really took off. So I'm not sure that we have found yet the frame that is going to energize our movement, but it's really important that we try to find that frame that energizes people. She also says, look, you're going to have folks that are adversaries. Figure out how you can work with them, and even figure out how you can work with business, and we do that. And I saw in your coalitions that you're also thinking about the local chamber, because the local chamber cares about the health of its population. And so you can find those kinds of allies. And then finally, she counsels us to be leaderful. And that means to be expansive, to not try to protect your turf, to recognize that we all have something to offer, and to really try to work in a more synergistic, less protective manner. Don't think about the resource constraints you have, rather think about, as a community, what are the resources that we can put together on the table. It's a terrific book, so I would recognize it. I'm going to try to go through these more quickly. So I'm really so impressed by the work that Michael Fine and many of the board of directors here in the room has been leading. I mean, I think that healthcare affordability, they say, is the #2 issue for voters. And so we can assert that primary care is a key solution to a problem that voters are raising as something that moves them in terms of candidates. I think we also know that movements generally don't happen from the top down. We talked about stories, and I think the other thing that is important about community-led movements is a lot of innovation comes from communities, comes from states, and then filters up. They are test cases for a lot of great ideas. So we've got a theory of change, and I would suggest that that is something that communities need to think about too. And really the question is, how do you win? That should be your central question. How do you win? For us, it's we build a diverse coalition. This diverse coalition, and I think this is what you all are doing, with data, with an acknowledgement of what the problem is, can start to merge together and consider how to move a policy. There creates a certain kind of urgency when different stakeholders are all saying the same thing to policymakers. When they're hearing surround sound from all different kinds of organizations with the same message, that creates urgency. We focus on payment. I think it's one of the critical levers at the federal level. You all need to decide where the most important levers at the community level. And I think we also need to acknowledge that if we're going to get more payment, we want to demonstrate what the results are. I was really pleased to hear about some of the DPC results. I've been wondering about the data for DPC. It's fabulous that there are now some results emerging. So I'm going to talk just very briefly about what we've been able to accomplish at the federal level, and then about what kind of work we might do together. So we have redefined primary care to focus much more on prevention and linkage to community, because what we know is that this energizes patients who want to be healthy. They don't want to just get care when they're sick. They want to partner with someone that can keep them healthy. I think if we had primary care that better integrated behavioral health and was much more focused on lifestyle medicine, we'd probably get the 20 and 30 and 40 crowd into our primary care clinics. We just need to meet them where they are, and I think most people want to be healthier. We've really focused on federal legislation and regulation, as I said. So the sorts of things we've been able to accomplish is a new bundle payment for primary care and Medicare, which is not tied to time requirements, and you get it every month. I think that there's a lot of excitement about it. We're going to be trying to foster implementation of it. It's in original Medicare, traditional Medicare is picking it up. We're asking commercial payers and Medicaid to consider doing so as well. It pays for services that primary care does, but are often not paid for, related to care coordination and integration. So it's a really important, and now it's integrating behavioral health. In the fee schedule, now this is very arcane, I hope nobody's head is going to explode. We're working on how do we change the way we value services. Why does this matter? Why does pricing matter? Because even when you change your payment mode, everything's based on the pricing of the services. And stark examples. Who's had a skin tag removed in this group? What? No one's had, one person has had a skin tag? Okay, a couple more. All right. So maybe 30 seconds? Maybe 30 seconds? The dermatologist is paid the same amount of money for that skin tag removal as a primary care clinician is paid for a complex visit with someone who has multiple chronic conditions that takes 45 minutes. Does that just burn you?
Yes, every day.
So we got to deal with pricing. We've got to deal with pricing, and the Medicare physician fee schedule took that step. So this crowd in Washington is willing to take steps that are not making the specialists particularly happy, are not making the hospitals particularly happy. And we want to build on those reforms. We also see ACOs as a really important value-based care model. Not every ACO. The primary care-centric ACOs, which we've been working with, their savings are 2 to 1 over the hospital-based ACOs, and they hit it out of the park on quality. So we know what works in the value-based care arena. We know we need to change pricing. These are tough, tough problems. We're going to continue to do this work at the federal level, but we really need your stories and your data and your energy, and we want to connect you with federal decision makers. Please sign up for our monthly newsletters and to attend our webinars. Please join our state safety net work group. And here's the slides that somehow got left out. And I just want to say one moment on that. And I do have time for, I do have time for questions, 5 minutes for questions. The thing that we all need to be ready for, and many of you are already experiencing this at the state and community level, is the cuts from HR 1. $1 billion, $1 trillion out of the healthcare system for the safety net over a 10-year period. This is going to have an effect on folks that you serve, that you advocate for, on your communities. It is going to put a lot of pressure on state decision makers to make decisions about healthcare dollars as their budgets tighten. And there are many other actors in the healthcare system with tremendous lobbying power, as Michael alluded to earlier, who are ready to make the case to state policymakers that, no, you can't help, you can't cut us because the emergency rooms will be full up. No, we're providing uncompensated care. Meanwhile, people are not going to be getting basic care. So it is critical, I think, and this can create a platform for change, for us to be cognizant of how these cuts are going to affect our communities. And I would suggest that this is, in addition to healthcare affordability, this is going to be an additional rallying cry for folks to come together to work at all levels of the system to advocate for primary care. Thank you, and there's a couple of minutes for questions. Okay, we have 3 minutes, so are there any questions? And there is a mic. I was going to say, you just need to assert your voice.
And thank you so much for your advocacy for primary care on a national level. You have a room full of people who are advocating on local levels and state levels, and some of the barriers, the biggest barriers we face are insurance companies and hospitals. Everyone wants to get theirs. In 2 minutes and 22 seconds, do you have any advice for us on how to overcome those barriers?
Well, I actually, I heard a lot of critique of insurance companies, and I have my own critique. But in terms of the business model, they're more aligned with what we're trying to achieve, because they're getting a capitated payment. Mm-hmm. Now, have they properly innovated in the primary care space? They have not. There are some examples of that. More of the local plans have done that. I know a lot of local blues plans that are innovating in primary care. We need to push the national plans. I actually think all of this movement towards DPC and direct contracting, the premises of the world of on-site and near-site care are pressures on the national health plans because they're being cut out of that relationship to primary care. And that makes them nervous. So this is another, I think, entry point. So the reason we really do need to be working with these insurer plans, and the reason I say that is when you go up to Capitol Hill, you need other powerful stakeholders. And the hospitals just, until we move to global budgets, the hospital financial model is just, the heads and beds model is really anathema to what we do in primary care, so I think it's harder. with hospitals. Now, there are hospitals that are exceptions and who understand that we're moving to population health. I feel like we should figure out how to make visible those hospital systems that are supporting primary care. So I don't believe in a, you're good, you're bad. I mean, the world is much more complex. So back to your question, I would find the insurers who want to work with primary care. I met with the CMO at Blue Cross Blue Shield Massachusetts on Monday, and that was an interesting conversation. Find the healthcare systems, we're almost out of time, who are primary care focused, and they exist. Look at Jefferson in Pennsylvania, doing incredible stuff in the primary care space. So that's my advice.
Thank you.
And I think we're out of time.
Right on time.
Thank you.